So Dr. Emmett Broxson is a pediatric hematologist who's been in practice for 24 years in the U.S. Air Force and now in the Children's Hospital in Dayton, Ohio. Professor of Pediatrics at the Boonshoff School of Medicine at Wright State University, Medical Director of the Hematology-Oncology Division, and Director of the Neuro-Oncology and Long-Term Follow-Up Clinic. As an oncologist, he's worked with children and families regarding palliative care and end-of-life issues for many years. Thank you very much for being here.
Everybody's in the back of the room, so let me come join you. What kind of brain tumors do we have? Beg pardon? Different kinds, okay. What do you have a child with brain tumor? Yes. Okay. What kind? Glioblastoma multiforme? Okay. Pineoblastoma? Okay. Okay. Anything else? DIPG? Okay. All right. Anything else? Okay. All right. Then, what is palliative care? Anybody got any idea? What's your frame of reference? What do you think it is? Near the end of life? Okay. Any other ideas? Beg pardon? Comfort care, okay. So a team effort at the end of life. So we heard beginning, I can't write by the way, to end of life. We heard about end of life care. And we heard about a team approach. Any other thoughts? Well, the World Health Organization has this definition. By the way, palliative comes from the word palliere, to cloak, which I'm not sure quite what that means, but that's the way it's described. And it is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses. And it's through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And I think we all came up with pretty much those ideas. And this pretty much goes through and describes in detail more about what palliative care is. It mentions relief of pain and symptoms, taking care of psychological and spiritual needs, support for the family, a team approach, enhanced quality of life, and it can be applicable in the early course of the illness. They further break it down for just children, and for the children, it involves not only the child, but also the family in providing supportive care. It begins when the illness is diagnosed and continues despite the therapy or irregardless of the therapy the child is receiving. The providers of care need to evaluate the family as well as the child, and it needs a multidisciplinary approach to it. And one of the things that's key here, it can be provided in a tertiary care facility like Toronto Sick Children, or it can be provided in the small community health centers, maybe like Dayton, Ohio, or even in a child's home. Now, what are conditions that are appropriate for this? And one of them is conditions for which curative treatment is possible but may fail, and that means cancer possibly. Now, we heard GBM, we heard DIPG, We heard pineoblastoma. We heard ependymoma. Do you think all those qualify for palliative care? I think so. Now, what if we had a low-grade glioma? Or same term, but a polycytic astrocytoma. What about those two? Thanks. Would those qualify? Yes, technically. They're less likely to have a problem with death than these are, but they certainly have potential. Especially if you had a child with a low-grade glioma that was diagnosed in the first few years of life and had a problem with failure to thrive. Those kids often die of their disease and become widespread just like the other things can. Other conditions, things that would require long-term treatment, and you would be aiming at quality of life, like cystic fibrosis. Conditions in which treatment is palliative from the beginning. That is, you're dealing with the end-of-life issues from the beginning, like trisomy 18. Or someone with a severe non-progressive disability that would cause extreme vulnerability to health complications such as anencephaly or a brain malformation. Okay, to move on, what is end-of-life care? Now, other terms for end-of-life care could be terminal care, and that is in which basically the child is imminently dying and it's very close in time. Or another term has been used as comfort care. Some end-of-life decisions that we're faced with. The one is therapy. What do we do about the disease that we're dealing with that's causing the child's death? Do we treat it or not treat it? Are we willing to provide something that will give the child a longer life, but less quality life? Those are some decisions they have to make. Pain management. Do we give oral things as long as we can, or do we give IV, or do we use patches that distribute the pain medication? All these things can be used. Can we use alternative medicines? Complementary medicines. What about nutrition and hydration? The child is going to die within the next few hours or a few days. Do we provide fluids? Do we provide nutrition? Or even within a month, and he can't swallow, what do we do? Do we use TPN? Do we use a tube that goes down the nose to feed the child? Those are some decisions that you'll have to make if you're facing this issue. What about other family members? Grandmother, the child's sibling. What do you tell them? How do you deal with that aunt who tells you, you shouldn't do this, you should do this? Those issues you'll face if you're in this situation. Resuscitation. Do you provide shocking? Do you provide drugs to start the heart? Do you provide electrical means to start the heart? Or do you just make the child comfortable? Place of death, this is probably one of the bigger decisions. Do I want my child to die at home? Do I want them to die in the hospital where they know everybody? almost as well as the people at home do? Do you want the child to die in a hospice facility if you have access to one? Those are things that you'll have to answer. Most people in my practice will choose to die at home. It's more comforting, I think, for everybody in that situation. Family involvement. Do you bring the siblings into the decisions that you make? Do you bring grandparents into the decision you make? And I think there's one that needs to be up there, and that's what about the child themselves? What you do about that child? Do they have a part in the decision? And I think almost any age, they will have some understanding, except maybe in the infant, of what's going on. And so you have to make a decision as how much you want to involve them and how much you want to tell them. The other decision is autopsy. You might say, well, I know what caused the death. But if there's some uncertainty in your mind, then you might want that autopsy to figure out exactly what happened, if they can. Or there may be extenuating circumstances around the death that you'd like to have that answer. I can tell you most folks don't undergo autopsies, but that is a preference that they have. Autopsy is especially nice if you have an unknown cause of death. Your child seems to be doing well, and all of a sudden there's a catastrophic event. That's a good time. And then lastly, some sort of funeral plans need to be made as quickly as possible so it's not a last-ditch effort to find a funeral home or facility to bury the child or cremate the child. And the other thing is that these don't come at you at one time, okay? They're decisions along the way. Back to the method over here. You don't make all those decisions on day one that you diagnose. Those are the course of time and the stage of the child, that the stage the child is at. Next term, hospice. What is hospice? This is by Medicare. This is a special way of caring for people who are terminally ill. And it involves a team approach, as we've talked about, and addresses all the situations that we've pretty much thought at this point. It's also a philosophy of care and that focuses on palliation of terminally ill patients. Or it's a hospice building. I'm going over to hospice to see my child. And in medicine at this point in time, in the United States, we've evolved to where we have, especially in hospice and palliative care, and it's also an interdisciplinary field that in our country. Okay, palliative care models. This is pretty much the one that was in vogue for quite some time, where you basically treat to cure, and then it comes to a point where you can't get much further, and then you just provide emotional and spiritual needs. And then you have death, and then you just have bereavement after that. This is a more current model in which when you start out, your purpose is to basically treat to cure, and then with time, if you start having problems in your treatment, then you add in some things here to help guide the patient through the rest of the life. Then you face the death, and then bereavement after that. This is putting it in other terms. This is the old model up top we talked about. And then the newer model has several layers to it. Cure-seeking care, life-extending care comes in there, depending on what the illness is. Then you have comfort and quality of life, maximizing care. Then you have the peri-death care or care around death. You have family supportive care throughout this, and then eventually bereavement care. But palliative care starts from diagnosis through death and afterwards. And I think that's the best model. And there are many advantages to having it come in early. That's very hard. I'm sure we can't overcome it for a long time. And as to your question, our program is called Care and Comfort. And that was the name we gave to it. And it's basically outpatient hospice care. So that I have people who can come in early on and try to get introduced to the families in the beginning and support them along the way. Now, I won't do it for everybody, but if I have a child with a DIPG, I would probably do that because the lifespan is so short. But there, again, I've had kids, I've brought the person in or other people, and they go on forever, but they know them. And so that when the time comes, they're familiar with them and they can go back and meet them and readdress things. It's especially true in cystic fibrosis, where there's a long life expectancy, really. But they have to make some of those decisions along the way too. What can happen in a very large facility is that you're working with an oncologist for a large part of the care, and then you reach that terminal stage and they bring in a palliative care team, okay? And that's shocking to your system. Whereas if they were involved in the beginning, it would be less shocking to you. But if I brought them in the beginning, I don't want to see that. I don't want to participate in that. That's what you would face. There are 3 phases of therapy trials. Phase 3 is generally what you start with. Phase 2 is where you're trying to figure out the efficacy of the drug. Phase 1 is where you're trying to see what the dose is for a drug. And there are stages that we go through, and parents do too. They're trying to seek out that drug that will be a magic bullet. So they go through those various phases. So a lot of families cannot give up hope. So they will keep seeking those drugs out. And that's fair. Just for us, a child has to have certain performance capabilities. Their kidney function has to be okay, et cetera, to provide some of those drugs. But they generally are available up until the time of death. My approach is to talk with the family and try to convince them that we need to stop and what's the best quality of life. But I will treat pretty much as long as the family really, really wants it. And a lot of the families just cannot stop. They've got to do everything to the very end.
Thank you to everyone for participating and sharing your insights and experience and questions.
Thank you.
Very much for coming.
Thank you. I hope this was helpful to you guys. Okay.